All right, so we'll go ahead and get started, and there may be some more people joining us. So thank you everyone for joining this case-based workshop. We are going to be talking this afternoon about calcium and bone disorder cases with a focus in topics in pediatric and transition age patients. These workshops are an opportunity to be interactive, and it looks like we're a small group, so if you do have questions, please feel free to put them in the chat or put them in the Q&A, or, just we're a small group, feel free to just, raise your hand, pipe up, and ask questions, and hopefully we'll have some nice discussions going. So to introduce myself, my name is Deb Mitchell. I am a pediatric endocrinologist here at Mass General Hospital in Boston, and I am the co-director of our Pediatric Bone and Mineral Metabolism Clinic. So I have a specific interest in disorders of calcium and skeletal and metabolism. So the focus of our cases today are going to be on patients that I see, so in the pediatric age range, but hopefully we'll be illustrating some more general principles of calcium and bone metabolism. So hopefully these will be interesting to folks, even if your clinical practice doesn't involve seeing children. So I'll go ahead and get started, and we'll dive right into our first case. So this is a patient who I saw a few years ago, a 12-month-old infant who presented to his fantastic pediatrician in our community for his 12 well child. Excuse me. And at the well child check, the mother mentioned to the pediatrician that she was worried because the baby had swollen wrists. So the pediatrician took some fantastic photographs, which she subsequently shared with me. And you can see what the mom was talking about. So these babies' wrists do look somewhat kind of widened and kind of bulbous. The baby also has some bowing of the legs, so what we call varus deformities. It can be very challenging in toddlers to try to figure out what's the normal physiologic varus of new walkers versus bowing that's in the abnormal range. But it's certainly the suggestion that this is maybe a little bit more bowing than would be normal for a 12-month-old. And then finally, looking at his growth chart, what you can see is the head circumference, which, like other things like height and weight, typically tracks along one growth line. You can see this 12-month check, his head circumference has gotten quite large, and that's unusual as well. So for some past medical history for this infant, he was a full-term baby born to a G6, P5, now 6 mother. The family is Haitian American. In terms of the diet history, the family is vegan. The baby is breastfeeding, and now that he's 12 months, he's eating some complementary foods, all of which are vegan, and he's drinking some almond milk. He was prescribed vitamin D in the newborn period, but as with so many of our families, there's a lot going on when you have a new baby in the house, and the prescription was not refilled by the family after he completed the first month of treatment. He was seen at his 1, 2, and 4-month well child checks. Everything appeared well. He missed his 6 and 9-month well child checks. Now he's here for his 1-year check. And his development seems quite on track. He was walking at 10 months, which, if anything, is slightly early. And his social and language development are really very appropriate for a 1-year-old. And here is his X-ray. So for those of you who aren't used to looking at pediatric X-rays, I've shown a knee X-ray here of a typical healthy 12-month-old on the left. And what you can see is this metaphyseal border of the distal femur is nice and sharp. You can see this unmineralized portion of bone between the distal metaphysis and the epiphysis here. This is the growth plate or the physis, and it's fairly narrow. And there is some widening of the distal metaphysis, but it's not too extreme. And now here we have the X-rays of our patient. So you can appreciate the differences here. So first of all, you can see that this physis, this unmineralized portion of bone between the metaphysis and the epiphysis, is very, very wide. And that this nice sharp border of the distal metaphysis is very kind of uneven and frayed looking. And then the bones, there's much more splaying of that distal metaphysis, both here at the distal femur, as well as here at the proximal tibia and the proximal fibula. And we see this very similar findings at the distal fibula and the distal tibia. You can also appreciate a little bit of the varus that you can see in this joint survey. So these are very abnormal x-rays. His pediatrician also got a set of labs. His calcium is low at 7.8 milligrams per deciliter. His phosphate is low for age at 3 milligrams per deciliter. His PTH is very elevated at 914 picograms per milliliter. His alkaline phosphatase is somewhere above the upper limit of the assay, so it's above 2,300 units per liter. And his 25-hydroxy vitamin D is low at 8 nanograms per milliliter. So this is not a diagnostic dilemma. This baby has vitamin D deficiency rickets. This is a very classic presentation when we see rickets present in this age group. And so let's just kind of review what else we might see or might be looking for. So the skeletal features we're looking for are bowed legs, and this can be, as in this infant, the varus deformity, so an outward bowing. We can also see a valgus deformity, so inward bowing of the legs. And sometimes one leg is in varus and one leg is in valgus, and this is called a windswept deformity. We see these swollen wrists and ankles, and that's kind of the external appearance of these widened metaphyses. We can see frontal bossing, and that's why this baby had this elevated head circumference. We can see a rachitic rosary, so we see that in this picture here. This is an infant who all of the distal ribs are widened, and so this almost looks like you're wearing a rosary. That's how it gets that name. We see delayed closure of the fontanelles. We see delayed tooth eruption, craniotabes, which is when you press on the skull bones on either side of a fontanelle. They kind of depress and pop back up like a ping pong ball. And these children, often it's unappreciated because they're often, minimally pre-verbal or minimally verbal, but they're in a lot of pain. And so often they'll be like an irritated or irritable child. Extraskeletal features that we look for, so we look for hypocalcemia. Sometimes it's asymptomatic, but can present with paresthesias, with tetany, with seizure, and in rare cases with a dilated cardiomyopathy. We see poor linear growth often. That low vitamin D can lead to a myopathy, so we'll sometimes see muscle weakness and delayed motor development, and we can have increased intracranial pressure, which can also lead to head pain and impaired vision. So we often think of nutritional rickets as kind of this like historical disease that if you read about in like a Dickens novel, but in fact, it's really quite prevalent and increasingly so. So in the 19th and early 20th centuries, in industrialized Western cultures, the prevalence of rickets in urban centers was on the order of 25%. And then fortunately, in the early 20th century, the etiology of rickets being low vitamin D was discovered, and various public health initiatives, including fortification of milk in the United States, other foodstuffs in Europe, really led to the near eradication of rickets at least in high-income countries. More recently, there's a rising incidence. So I'm showing here in the graph data from the Rochester Epidemiology Project, which covers essentially all children in the Minnesota area. And what you can see is in the 1980s, there was only one child in that entire decade who presented with rickets. In the 1990s, there were 2, and then you can see multiple across the next decade. And that's what we're seeing anecdotally in our practice as well, that increasing numbers, several children presenting with rickets every year. And while we tend to think about the incidence of rickets in high-income countries, in fact, in low and middle-income countries, it's never gone away, and particularly in situations where there's military conflict, children don't have reliable access to food, it's not safe to go outside. The prevalence can be up to 25% still in low and middle-income countries. So what are the risk factors for nutritional rickets, and which of these does our patient have? So open it up to the audience. You can speak up or put it in the chat. What might be his risk factors? All right, so we can talk through some of the more common risk factors. And these were nicely delineated in 2015 in a case finding survey in Canada. So pediatricians were asked to report whether they'd seen any cases of rickets in the past year, and if so, give a case history. And these were the risk factors that were pulled out from that survey. So number 1 was maternal vitamin D deficiency. Number 2 is deeper skin pigmentation, which leads to less UVB absorption and less endogenous vitamin D production. Lack of use of vitamin D supplementation, lack of sun exposure, which is super common in northern latitudes during kind of late fall, winter, early spring, or in people who aren't going outside, developmental delay, feeding challenges, particularly in the setting of prematurity, food allergies, and dietary restrictions. So for our patient, he does have deep skin pigmentation. He was not getting vitamin D supplementation, and his family and he are vegan, so there are dietary restrictions as well. And this is what we commonly see, is that it's not just one thing. Our patients with rickets often have a combination of factors that have led to this situation. So what is the serum concentration of 25-hydroxy vitamin D that prevents rickets? And I invite people to share their thoughts here. Well, the answer is there really is no one single answer, and it's really dependent on the dietary calcium intake. So the job of vitamin D is to increase the percentage of our calcium that we absorb from what we eat. So in the absence of any vitamin D, our guts absorb approximately 10% of the vitamin D that we're eating. With adequate stores of vitamin D, we triple this, so we absorb roughly 30% of vitamin D. But what this means is that if we have adequate vitamin D and are eating a very calcium deficient diet, we can still develop rickets. And conversely, if our, so someone said shoot for a 25D of greater than 30 nanograms per milliliter. Yeah, and that's the Endocrine Society recommendation for adults from optimal health. On the other hand, if we have someone who's getting lots and lots of calcium in their diet, they can probably get away with a lower 25-hydroxy vitamin D and probably aren't going to get into too much trouble, at least in terms of skeletal metabolism. There is a consensus guideline for pediatric rickets, and that guideline says when the 25-hydroxy vitamin D is greater than 12 nanograms per milliliter or greater than 30 nanomoles per liter, rickets is rare. We haven't made it impossible. We haven't ruled it out, but rickets does become rare. And these are data from a case control study of children in Nigeria with rickets that Tom Thatcher and his group have been studying for quite some time. These patients in general have what we would consider adequate 25-hydroxy vitamin D levels, but dietary calcium in this community is very, very low. There's just very little dairy that's a natural part of the diet in this community. And the more common sources of calcium historically in the diet in this community had been dark green leafy vegetables, lots of roots and tubers and nuts and seeds. And as the diet has been transitioning to a more Western style diet, children have been consuming less of these foods. So they're left with dietary calcium deficiency. What you can see following the green curve, looking at the odds of nutritional rickets on the y-axis and the serum 25-hydroxy vitamin D along the x-axis, for the kids who are getting at least 300 milligrams of calcium per day, which is not great. The RDA for children is 750, but they're getting at least 300. Their odds of rickets don't really begin to rise until the vitamin D gets under about 14 nanograms per milliliter or so. Conversely, if we're looking at the kids who are only getting on average 130 milligrams of calcium per day, they have a risk of rickets even with what we would consider an adequate 25-hydroxy vitamin D serum level, and that goes up to, the rickets is almost universal at a serum 25-hydroxy vitamin D of about 10 or so. So it's it's a dependence on both the calcium intake and the vitamin D. So back to our patient, we have a kiddo, he's got nutritional rickets. What are we going to do for him? Are we going to give him 50,000 units of cholecalciferol? 2,000 units times 2,000 units of cholecalciferol daily for 3 months, 400 units of cholecalciferol plus 500 milligrams of calcium daily for 3 months, or 2,000 units ergo plus 1,000 milligrams of elemental calcium daily for 3 months. And I think I can enable this poll, so give people a few minutes and you can put your answer into the poll. All right. I'm going to end the poll. I'm not sure if people can see the answers. We've got 1 vote for 2,000 of ergo. We've got 2 votes for 400 of cholecalciferol and 500 of calcium. and 2 votes for 2,000 of ergocalciferol and 1,000 of calcium. Oops, share results. Here we go. All right. So answer D is my typical approach and what's recommended. And it's really important, we'll talk about that it's not just a question of giving back vitamin D, but we really need to give back calcium as well. So these are the recommendations from the global consensus recommendations that I had mentioned. And the treatment dose for vitamin D for infants under 3 months or infants 3 to 12 months is 2,000 units a day. For infants who are for children who are older than 12 months but less than 12 years, the recommendation is somewhere between 3,000 and 6,000 units of vitamin D, and for children older than 12, it's 6,000 units of vitamin D. Or options for a single dose of vitamin D. There's no safety or efficacy data for small infants, but for infants 3 to 12 months, a single dose of 50,000. For children 1 to 12 years, a single dose of 150,000, and for children over 12, a single dose of 300,000 IUs. The consensus guidelines do recommend that daily dosing is preferred when it's feasible because the risk of hypercalcemia is higher with a single large dose. However, they recognize that in certain clinical situations, it may not be feasible to expect patients to be able to administer a daily dose. So we do have this single high dose recommendation available. For the daily dosing regimens, because these are high doses, though the absorption of ergocalciferol or the conversion of ergocalciferol to 25-hydroxyvitamin D slightly less than efficient with chole, given that we're giving higher doses, the efficacy between these two is very similar, and there's no need to really stress about that. It's really important at the same time to give back calcium because what we're trying to do is remineralize these osteomalacic bones. Also, once we start treating the vitamin D deficiency and PTH comes down, much like in patients with hyperparathyroidism, where we're doing a parathyroidectomy, we are at risk of giving patients hungry bone syndrome. So the dose recommendations for calcium are quite variable. Some recommendations are fixed doses of between 500 to 1,000 milligrams per day. Some guidelines suggest weight-based dosing of 30 to 50 milligrams per kilo per day. The one study that's looked at this sort of in a randomized fashion, again, is from this Nigerian group studied by Tom Thatcher and his group. So what you can see here in this graph is the rickets severity along the y-axis, and then along the x-axis, the weeks of treatment. In blue is the children given a flat dose of 500 milligrams. In red, a flat dose of 1,000 milligrams. Again, this is elemental calcium. And in yellow, the children given 2,000 milligrams. And what you can see is at week 24, the 1,000 and 2,000 milligrams are more effective at decreasing the rickets score than the 500 milligram dose. And so in order to get the maximal efficacy without risking hypercalcemia and hypercalciuria, in general, people are giving 1,000 milligrams daily to these patients. Once you've either treated your patient or in order to try to prevent the initiation of rickets, there are recommendations for primary and secondary prevention. So for infants, the recommendation is that infants get 4,000 IUs of vitamin D daily, as well as at least 500 milligrams of elemental calcium daily. For older children, the recommendation is 600 units of vitamin D and 500 milligrams of calcium. So Jeff Medlin is asking, since kids have growing bones, unlike adults, I expect an elevated alkaline phosphatase, and that's absolutely correct. That alkaline phosphatase reference ranges are different in adults and in kids. PTH levels in kids and adults, the reference ranges are identical. So we're still looking for that same, a high level in adults is the same as a high level in kids. Great question, thank you. All right. So in terms of takeaways from this first case, number one is this: I want everyone to recognize nutritional rickets is not a historical relic. We still do see it. To be alert for the many risk factors for nutritional rickets, and to understand that nutritional rickets at the end of the day is really not simply vitamin D deficiency, but it's an interactive deficiency of calcium and vitamin D. So before I move on to our next case, any other thoughts or questions about this case from anyone? All right, so let's move to our next case. So now we've got an older kid, we've got a 12-year-old, and her initial presentation was several months of bilateral knee pain. She initially was referred by her pediatrician to a pediatric orthopedist for this complaint. The pain was not terrible. She could walk, she could get through her activities of daily living. What she really noticed was after significant exertion, her knees hurt. And in fact, she was a competitive soccer player. She was a goalkeeper, which in retrospect, she thinks maybe she chose that position because it involved a little bit less running than other positions. But she was able to play sports. And the mom also noticed that she appeared, in her words, knock-kneed. And so these two complaints prompted um, her referral to pediatric orthopedics. And here is her imaging. So what you can see first in this joint survey is exactly what mom described. So she does have a bilateral valgus deformity. So her knees are bowing inwards. And you can see that that angle is a little bit higher on her right than on her left. And then if you look a little bit more closely at these joints, somewhat similar to our patient with nutritional rickets, we do have widening of these physes, but it's much more patchy. So we have this area of lucency here in the lateral portion of the distal metaphysis of the femur and kind of in the medial portion here on the left. The tibias look pretty good. Maybe there's a little bit of lucency here, and then there's a lucency here in the proximal fibula here. So going back, getting a little bit more history from her, she's overall been a healthy kid. There's no history of fracture. She is of European ancestry. She has no dietary restrictions and loves her dairy, drinks plenty of milk and ice cream and yogurt and all those things. Overall, she has a history of her teeth erupted late, but no other dental problems, no infections or cavities. Family history, there's no metabolic bone disease. There's no history of musculoskeletal symptoms. Of note, mom does have a history of multiple dental infections and she's needed multiple root canals. So here are her labs. So her calcium is 9.6. Red is normal. Her phosphate is 3.1. Red is a normal. Her 25-hydroxy vitamin D is 22. Her 125D is 46. Her PTH somewhat elevated at 75. Her alkaline phosphatase is 298, which, as our commenter noted, is totally fine for kids. We expect that to be high in kids. And her urine calcium to creatinine ratio is not elevated. It's totally normal. So what do we think this young lady has? Does she have a malabsorptive disorder that's giving her nutritional rickets? Does she have X-linked hypophosphatemic rickets? Does she have hypophosphatasia, so low alkaline phosphatase? Or does she have a metaphyseal chondrodysplasia? So this one, unfortunately, is not set up as a poll. So you can shout out your answer or throw it in the chat. All right, not seeing a lot of takers on this one, so I'll just move forward. And she has X-linked hypophosphatemic rickets. So you may be asking, but you just said her phosphate was normal. Phosphate is one of the ones that is very, very different in children than in adults. So these are data from the Caliper study, which we really rely on a lot in pediatrics. This was a study across Canada. They measured hundreds of metabolites in healthy children in 9 sites across Canada, and then developed age-specific reference ranges. So if we look at phosphate here, we've got boys in the blue, girls in the pink. I did not design that color scheme. It's not what I would have chosen, but here we are. And what you can see is in infancy, serum phosphate levels are very high, and that has to do with just immaturity of the neonatal kidney. They settle out by about the first year of life, but they settle out at a higher range, so around 4 to 6.5, and they stay in this higher range until towards the end of puberty when they start ducking down more towards the adult reference range. So you can see in girls around age 13, 14 is this inflection point where the means become lower, and in boys around 14 or 15, they become lower. So if we look at our patient, she's 12, her phosphate is 3.1. This is grossly abnormal for age. So let's go back and look at her labs now that we understand that this phosphate is low. So her phosphate is low, her 25D, again, adequate at 22. Her 125D, though it's normal at 46, she's got hypophosphatemia. So hypophosphatemia should stimulate activity of the 1-alpha hydroxylase and raise 125D in order to try to promote increased phosphate absorption from the gut. So this is an inappropriately normal 125D. Her alkaline phosphatase is is normal. Her urine calcium to creatinine is fine. And what I didn't tell you before is her tubular reabsorption of phosphate is low. So to calculate the tubular reabsorption of phosphate, we need a fasting morning second void. We measure the phosphate and creatinine in the urine. We measure simultaneous phosphate and creatinine in the serum, and we can calculate the TRP. In the setting of hypophosphatemia, that TRP should be 95%, realistically should be 98, 99%. So 93% means that she has renal phosphate wasting. And so Jeff Medlin is asking, do we measure FGF23 in these folks? And it actually turns out that there's a fair amount of overlap in FGF23 levels between people with XLH and kind of the normal reference population. So sometimes they're quite high, and sometimes they can look like they're in the normal range, which is, again, is probably inappropriately normal, but they end up not being terribly diagnostic. So looking for renal phosphate wasting, and then the next step, getting genetics, is really kind of the diagnostic pathway if we're thinking about XLH. So for this young lady, we then did get genetics. And in fact, she does have a mutation in the PEX gene, which is the gene responsible for hypophosphatemic rickets. It's X-linked, so it's a heterozygous dominantly inherited mutation. So heterozygosity is enough to confer disease. All right, so XLH, how reliable is the genetic testing in this condition? The genetic testing is really quite good. There are occasionally variants of unknown significance, but because there's a lot of interest, particularly now that there's new therapies that we're talking about, there's more and more genetic testing because there's a treatment available. So for example, I have one young woman who, she's little, she's like 6, where she clinically had a diagnosis of XLH. She had a variant of unknown significance in the PEX gene, which we then were rapidly able to resolve with help of the genetic testing company to show that this in fact wasn't the disease-causing mutation. What is the pathogenesis of XLH? So we don't exactly know the pathway that links the mutation in PEX, which is a metalloprotease, to an increase in FGF23. That pathway is still yet to be worked out, but what we see ultimately is that there is a inappropriately elevated level of fibroblast growth factor 23. So what does FGF23 do? It does 2 important things. First, in the distal tubule of the kidney, it decreases the expression of NaPi2A and NaPi2C on the tubule, decreasing the reabsorption of phosphate from the urine. So essentially, it just promotes excess phosphate excretion from the kidney. In the proximal tubule, it will also block the 1-alpha hydroxylase and increase the 24-hydroxylase. So it decreases production of calcitriol and increases the metabolism of calcitriol, so those calcitriol levels are low. That also impairs absorption of phosphate from the gut. And ultimately, the combined action of these 2 things is to lower the serum phosphate. So it's the hypophosphatemia that then is what causes the symptoms, signs and symptoms of XLH. So how does XLH present? It can present just as an R patient with rickets and osteomalacia. In more severe forms, it can cause craniosynostosis, so premature fusion of the fontanelles in growing children, leading to skull deformities. That's probably a 125D dependent effect. Children with XLH have progressive leg deformities. And in general, even with optimal treatment, about 1/3 do need at least 1 orthopedic surgery. Children with XLH and adults have chronic pain, both from a myopathy as well as the osteomalacia. They have low growth velocity and a disproportionate short limb dysplasia. In terms of dental effects, there is delayed tooth eruption as in our patient, as well as multiple tooth abscesses, which our patient's mother had, and we retroactively were able to diagnose the mother with XLH. And then there is a myopathy associated with this hypophosphatemia. So diving in a little bit more into the impaired growth. So what I'm showing on the left is growth curves from a large French cohort of patients with XLH have been followed by Agnes Linglart and her group. And what you can see is that the growth curve kind of superimposed along a typical chart is that the folks with XLH are shorter than folks who are unaffected. The average adult with XLH, the average male is about 5'3" or 160 centimeters. The average woman is about 5'5" or about 153 centimeters. So this is about 5 feet or roughly 10 to 12 centimeters lower than the reference population. I mentioned that it's a disproportionate short stature. So if you look at sitting height, which basically is a measure of the height of the spine, the Z-score is about -1 and doesn't change with growth. Whereas you look at arm length or leg length, those are closer to -1.5 or -2 and progressively decrease over time. So the stature will decrease over time and the sitting height is relatively protected, whereas the appendicular arm and leg length tend to be lower. And then diving in a little bit more into the dental health. So as I mentioned, patients with XLH will have delayed tooth eruption. If you look at a model of the tooth here, this enamel layer is thin and there's microscopic cracks in it. This dentin layer here, interior to the enamel layer, is abnormally thin and is abnormally mineralized. This cementum layer, which holds the tooth into the alveolar bone of the jaw, is thin. And these three things all combined mean that bacteria can get into these cracks and crevices, and it's so leading to the multiple dental infections that patients with XLH often have. And importantly, dental health is improved with treatment. So these are really cool scanning electron microscope pictures of, first here's a normal tooth, and you can see this dentin layer is very, very nice and smooth. And you contrast this with the dentin layer of a patient with XLH. You can see it's kind of bumpy looking. And then with increased magnification, what you can see is there are these globules of dentin and then these sort of spaces, unmineralized spaces in between. And then what you can see here is a patient who was undiagnosed and untreated for this period of their life. And then in this period of life where it's getting treatment. And so you can see kind of a pretty sharp delineation where there's normally mineralized dentin and then abnormally mineralized dentin here. All right, so what are we going to do to treat our patient? We can give her phosphate, we can give her phosphate plus calcitriol, or we can give her a monoclonal antibody against FGF23. So conventional therapy. Up until a few years ago, we just gave back phosphate and we gave back calcitriol. So what's missing, we give it back. There's not really clinical trial evidence to help guide us in what those doses are. We rely on expert guidance. So for phosphate, the doses tend to be somewhere in the 20 to 40 milligrams per kilogram per day range, given in 3 to 5 divided doses. As you might imagine, giving a child a medication 3 to 5 times a day is really challenging for a family. And once these kids hit adolescence and they're a little bit more independent, the adherence to this kind of regimen is very, very poor. For calcitriol, we give back roughly 20 to 50 nanograms per kilogram per day, and that's divided twice daily. And as I said, these doses really are just sort of based on expert guidance. We don't really have good clinical trial data to guide that. So in addition to being just sort of a pain in the neck, there's a lot of toxicities associated with this medication regimen. So that phosphate causes a lot of GI side effects. The calcitriol, if you're not careful, you have to give enough to try to treat the symptoms, but not too much because you can cause an absorptive hypercalciuria and even a hypercalcemia. Somewhere between 30 to 70% of patients with XLH will have some degree of nephrocalcinosis. And the phosphate, in addition to causing the GI toxicities, can cause a secondary and ultimately a tertiary hyperparathyroidism. So a lot of these patients end up either on cinacalcet or needing to go for surgical removal of parathyroid glands. And here I'm showing a scatter plot showing the mean phosphate dose along the y-axis and grade of nephrocalcinosis along the x-axis. And you can see that there's a positive correlation. So it's not simply the calcitriol that can cause the nephrocalcinosis, but the phosphate probably by inducing a surge of PTH that can also play into this nephrocalcinosis. So you're really trying to thread a needle, and it can be very challenging. So more recently, we have another option for treatment, and that is burosumab. So burosumab is a monoclonal antibody against FGF23. And this was the trial that led to its approval in children. This was a phase three trial involving 61 children ages 1 to 12 years. All had to have severe rickets. So on that Thatcher rickets scale, they had to have a 2 or greater. Importantly, every kid in this trial was already on calcitriol and phosphate therapy. And then they were randomized either to conventional therapy or burosumab for 60 weeks. And outcomes were assessed at 40 and at 60 weeks. So in this panel B here, what you can see is at baseline, the mean rickets severity score was 3. We have the kids treated with the conventional group shown in pink and the kids treated with burosumab in blue. So what you can appreciate in 40 weeks, first of all, is that both groups got better. And that's because all these kids were presumably being treated in centers with expertise in the treatment of XLH. So probably the calcitriol and phosphate doses were being treated a little bit better than they were by their local endocrinologists. But what you can see is that there's a dramatic difference in the patients who were on conventional treatment versus burosumab. So the patients on burosumab had a much better improvement in their rickets than the patients on conventional therapy. And this was also true at week 64. If we look at alkaline phosphatase as a marker of osteomalacia, what we can see is there was really no change over time in the alkaline phosphatase levels in the patients on conventional therapy, but a nice decrease down to the normal reference range by week 64 in the patients on burosumab. And then this is a quote unquote typical patient being treated with burosumab. You can see their x-ray at baseline, where we have a lot of these patchy lucencies here in the proximal tibia, here at the distal femur. And what you can see is the proximal tibia is really quite well healed. There's still a little bit of rickets in the distal femur, but it certainly looks better than at baseline. And it's important to note that the mean patient, even at 64 weeks, still had some degree of rickets. This is not a perfect treatment, but it's substantially better. What about other outcomes that we might care about? So I mentioned that people with XLH have myopathy, they have pain. So these are self-reported quality of life scores. So this is a PROMIS pain interference score. This gets out to what degree do patients feel that pain is interfering with their daily activities. This was administered, this questionnaire, to all children who are 5 and above in this trial. The numbers get pretty small. So there were 15 kids in the burosumab arm, 20 kids in the conventional arm. So you can see pretty wide confidence intervals. But what you can see is on conventional therapy, there was really no change in this pain interference score. But on burosumab, there was a statistically significant difference at week 40. And it was thought that this was a clinically significant improvement in pain. Very minimal difference in the change in physical function mobility score, although maybe if the sample size was bigger, we might have seen that this is a significant difference favoring burosumab. And then if we look here at the fatigue score, there was a significant improvement in the burosumab group, but not in the conventional therapy group. So suggesting that not only are the numbers getting better and the x-rays getting better, but people on burosumab are feeling better, which is an important outcome. So back to our patient, what did we opt to do? We opted to treat her with burosumab. The pediatric dosing is every 2 weeks. This is different if anyone here is familiar with adult dosing where it's given every 4 weeks. We sort of titrated the dose to the phosphate, keeping it in the age and sex reference range. Her knee pain got 100% better. She did undergo right hemiepiphyseal, I can't say this, epiphysiodesis procedure. So this is sometimes called a figure of 8 procedure where the orthopedist will put a clamp in on one side of that growth plate. Sometimes it's called a guided growth procedure as well to allow for normalization of that valgus deformity, and that healed up and they were able to remove that plate. So an ongoing question is now, how do we transition patients on burosumab as they become adults? So my patient, she's now almost 17. She's 3 years post-menarche. She's done growing. All those growth plates are fused. She's no longer at risk of rickets. So what do we do? So we could continue the pediatric dosing every 2 weeks until she's 18, where she's technically no longer a child. We could transition her to an every 4-week dosing strategy like it's given in adults with severe XLH. We could transition her to phosphate and calcitriol, conventional therapy, or we could just take her off therapy, as some patients with XLH do well and don't need any treatment. So what do we know about XLH in adults? It's a really wide continuum. So rates of fracture or pseudofracture are reported as anywhere between 18 and 52% of adults with XLH. Muscle weakness is a complaint in about 60% of adults. Early onset osteoarthritis, which probably has to do with enthesopathy, so calcification of ligaments, which really, if you look at it on biopsy, is really not so much calcification as actually a transition of those chondrocytes to osteoblasts. And the enthesopathy, which I mentioned, spinal stenosis, dental abscesses are super common, and hearing loss is common as well. We don't have real good guidance about how we manage this transition. So again, as I mentioned, there's a wide spectrum of disease. This patient's mother had felt great, was living, a very, other than her root abscesses, her dental abscesses and need for root canals, really hadn't been troubled by any musculoskeletal symptoms, despite the fact that she was undiagnosed and not on any treatment. We do know that both conventional therapy with phosphate and calcitriol, as well as burosumab, do improve bone mineralization, pain, stiffness, and fracture healing in adults with XLH for whom those are problems. Conventional therapy may improve dental health. There's no data to suggest that at this point. We don't really know about burosumab, whether that improves dental health in adults. In that pediatric phase 3 trial, there was actually a suggestion that dental health actually got worse in the burosumab arm, although that may have just been a question of small sample size. We're kind of not seeing that now in real world use, but it is an ongoing area of study. And conventional therapy, phosphate and calcitriol, may not prevent the hearing loss, the arthritis, the enthesopathy, and spinal stenosis. And importantly, we just have no trial data in adolescents. So our patient, we had a conversation with a family, went over all of this. She was really tired of getting Q2-week injections. So she was hopeful to try to come off of therapy. Her mother was not on treatment and was doing well. But she was a little bit hesitant about coming off therapy while she was in her sports season. So her decision was made, let's wait for the current sports season to finish. Let's transition to calcitriol monotherapy, which her mother was on, and hadn't had any more dental infections since she'd been treated. So off treatment, she felt well. She was totally asymptomatic. What you can see, though, is we redid her labs at 3 months, and she's quite hypophosphatemic. Her serum phosphate is 1.5. Her 25D is inappropriate. Her 125D, I'm sorry, is inappropriately normal at 18. Her PTH is not elevated at 41. Her alkaline phosphatase is normal for age. She's not hypercalciuric. We opted to increase her calcitriol dose. Her phosphate's a little better. She's still completely asymptomatic. So at this point, we're just continuing to monitor. If she were at any point to become symptomatic, we would think about either going to full conventional therapy with phosphate and calcitriol, or potentially to burosumab, and that's just going to be an ongoing conversation with her and her family about what the best options for her are. So takeaways from this case: one is to be alert to age-specific analyte reference ranges in pediatrics. If you're not certain whether the lab that you are using has pediatric reference ranges, you can look at Caliper or any of another number of other reference range websites to try to figure out if this is appropriate for children or not. Both conventional and novel therapies are effective in pediatric XLH, and burosumab does appear to be more effective in patients with severe disease. For our kids with more mild disease who have Ricketts scores of less than 2, we still don't know what the best option for those kids is. And we certainly need ongoing research to address additional complications of XLH. All right, before I move on to our last case, thoughts, questions about that case? A female teen with XLH who's pregnant, how hard are they to manage? That is a fantastic question, and one that I have not personally come across. So I will defer that to my adult colleagues. I don't know if other folks here have anything to add to that. All right. Our last case is now a young woman, so she's in the adult age range, although she was referred to pediatrics. So she was initially seen in the ED at age 18 for pelvic pain and menorrhagia. Incidentally, on a workup for this, found to have an elevated serum calcium of 10.8. She came back to the ED a month later, this time with a complaint of headaches. Her calcium was normal at 9.6, although her iCal was slightly elevated at 5.3. Additionally, notable labs, her 25-hydroxy vitamin D was not elevated, but certainly higher than we normally see at 68 nanograms per milliliter, and her PTH was suppressed at less than 7. She was seen a few more times with labs being serially checked, and what you can see is in green, her calcium was always either just above the reference range or kind of flirting with that upper limit of normal. She had her phosphate measured only once, and it was slightly low. Her 25-hydroxy vitamin D was always a little bit on the high side. Her PTH was always suppressed, and her 125D was also consistently high. She had one 24-hour urine calcium. She had so much urine out that she actually filled the jug. So all we know is that she had at least 340 milligrams of calcium, presumably more in her urine. So she's hypercalciuric. So at this point, she has a PTH independent hypercalcemia. So some additional history. She lives in Minnesota. She had just moved to Boston for college, which is why I was seeing her. Her diet was a fairly typical adolescent diet. She did avoid dairy because of GI symptoms, although she did have plant-based milk, but only a couple servings per week. She had a standard multivitamin. She remembered to take it once or twice a week. Symptom-wise, she'd had some fatigue over the last few months, wasn't sure if that was related to starting college or not. And she had some nausea, abdominal pain with eating, unclear if that's because she was now eating at the calf and the food wasn't agreeing with her or whether that was something more significant. She had never complained of any flank pain, never had any gross hematuria. On many of these UAs that she'd had in the ED, there was always a note of trace to large blood, but that had always been attributed to menstruation. Her past medical history was notable for endometriosis, and she was on treatment with OCPs for that. There was no pertinent family history, so no known history of hypercalcemia, known history of parathyroid disease, no history of kidney stones. So possibilities for her hypercalcemia. She could have vitamin D intoxication. Could she have hypercalcemia of malignancy? Could she have sarcoidosis, or could she have some other congenital bone and mineral ion metabolic disorder? So let's talk a little bit more about PTH-independent hypercalcemia and what our differential is. So if PTH is not driving this hypercalcemia, this suggests that something downstream of the PTH is being activated. So either we have increased absorption from the gut, that's PTH independent, we have increased reabsorption of calcium in the kidney or impaired calcium excretion from the kidney, or we have increased resorption of calcium from the bone. So let's talk about how could we get increased absorption of vitamin D of calcium from the gut. We can have that from vitamin D intoxication. So we just have too much 25-hydroxy vitamin D. Excess 125D, we can see that in granulomatous disease. So we can see it in sarcoid, congenital granulomatous disease, tuberculosis. We can see this in malignancy. So some neoplasias make 125D as a paraneoplastic phenomenon. And we can see that in 24-hydroxylase deficiency. So 125D is not being catabolized properly. We can also see that in Williams syndrome. We're not entirely sure why we have hypercalcemia in Williams, but we think that there's excess gut absorption. In terms of excess bone resorption, we can see this in sudden immobilization, so particularly in folks with spinal cord injuries or severe burns. We can see it in malignancy either from local osteolysis or from paraneoplastic production of PTHRP, thyrotoxicosis, vitamin A toxicity, hypophosphatasia, so insufficient alkaline phosphatase, and the calcium can't be crystallized into hydroxyapatite, so just stays in the circulation. Particularly, we see this in younger children, and we can see it in adrenal insufficiency, although it's not entirely clear why adrenal insufficiency leads to increased bone resorption, but it's a phenomenon that we see. And in terms of diminished renal excretion, we can see that in milk alkali syndrome, and we can see this in rhabdomyolysis. So in terms of our patient, her alkaline phosphatase is 126, normal for age. Her TSH is 0.92, so it doesn't look like she's thyrotoxic. Her vitamin A and retinol palmitate were in the reference range. She had a normal SPAP, very rare to see multiple myeloma in this age range, but checked for it. She had a normal CBC and smear. It doesn't rule out a malignancy, but makes it less likely. Her PTH-RP was in the reference range. Her renal imaging did show multiple non-obstructing stones, so this has likely been a long-standing hypercalciuria. So additional tests we can order. We ended up ordering vitamin D metabolites. So her 25-hydroxy vitamin D at this point on this test was 108, so quite elevated. Her 24-25 dihydroxy vitamin D was 0.21. So we can calculate a ratio of 25 to 24-25 dihydroxy vitamin D, and that reference should be less than 80. In her case, the ratio was 514, suggesting that 25D was not appropriately being converted to 24-25 hydroxy vitamin D, not appropriately being catabolized. The interpretation that came from the lab on this test was that ratios are greater than 80 indicate probable biallelic CYP24A1, that's the gene that encodes the 24-hydroxylase, mutation or deletion, and confirmation with molecular testing is recommended. So what is 24-hydroxylase deficiency, or what used to be called idiopathic infantile hypercalcemia? It's no longer idiopathic, and we're increasingly recognizing that it's not limited to infants. So normally, vitamin D is metabolized by a 25-hydroxylase in the liver to 25-hydroxy vitamin D. This is then activated by a 1-alpha hydroxylase to 1,25 dihydroxy vitamin D. This is the active form of the hormone that binds effectively to the vitamin D receptor and leading to all the downstream effects. So both 25D and 125D are catabolized by a 24-hydroxylase, leading to inactive products and ultimately excretion. This 24-hydroxylase is activated by 125D as well as being activated by FGF23. If we don't have a 24-hydroxylase or an ineffective 24-hydroxylase, we have a buildup of 25D. We also have a buildup of 125D, that active hormone, and that leads to the hypercalcemia and the hypercalciuria that we saw in this patient. So what are we going to do for her? Are we going to ask her to avoid dietary calcium and vitamin D? Are we going to ask her to avoid exposure to sun so that she's not endogenously making vitamin D? Should we tell her to drink lots of water so that she doesn't get more kidney stones? Should she have a low sodium diet to try to avoid kidney stones, or all of the above? And the answer is we don't have any targeted therapies at the moment. And what we really want to do is all of the above. We really want to try to minimize the calcium going into the system, both by minimizing dietary calcium as well as minimizing vitamin D. And we want to try to prevent these kidney stones. So what happened to this patient? She started being really good about her diet. Her follow-up urine, 24-hour urine, a month later was 227 milligrams, so kind of close to the normal range. 3 months later on follow-up, she'd sort of fallen off the wagon in terms of the dietary restrictions, and now her 24-hour urine again was elevated at 375 milligrams. We did a repeat. Yes, thank you for your question. We did a repeat image, and she has an increasing stone burden. She did undergo bilateral lithotripsy for that. And to your question, yeah, we did. We can use hydrochlorothiazide, or in this case, we used chlorthalidone to try to reduce her urinary calcium. So it's an imperfect therapy. We just sort of do the best we can. Are there any other options that we can try? So there is a literature about using azole antifungals to try to inhibit the 1-alpha hydroxylase. So there are several case reports in the literature of patients who have been treated effectively with ketoconazole, but there is concern about chronic use of ketoconazole and potential toxicities to the liver. There is also one case report of effective use of fluconazole, but again, concerns about liver toxicity with these agents. What about an alternative catabolic pathway? So there is a CYP3A4, which is an alternative pathway for the catabolism of 25-hydroxy vitamin D and 125D. Under normal circumstances, this is a tiny proportion of the overall catabolic pathway of 25 of vitamin D metabolites, but it was initially identified by Wong and colleagues in 2012. In 2018, Roizen and colleagues at CHOP found a kindred who had rickets that seemed to be resistant to vitamin D treatment. So these children were getting very, very high doses of vitamin D. They couldn't treat the rickets. They couldn't keep their serum levels of 25D and 125D up. And there was no indication these children had any generalized malabsorption. When they did initial mass spec to try to figure out what was going on with the vitamin D metabolites and ultimately genetic testing, what they found was that this kindred had a mutation in CYP3A4 that upregulated this alternative catabolic pathway. And that's why they couldn't maintain serum levels of 25D and had resistant rickets. These investigators then reasoned, well, can we take advantage of this pathway in patients with 24-hydroxylase deficiency to provide an alternative catabolic pathway? And they recognize that CYP3A4 has been well described to be upregulated by rifampin, which is why when we're giving rifampin, we have so many warnings about interactions with other medications. So this is a proof of concept study that was reported in 2 patients with 24-hydroxylase deficiency. And so what you can see is the time period on which they were on rifampin as compared with the baseline time period. Both of these patients at baseline had elevated calcium, had suppressed PTH, had either elevated or inappropriately normal 125D, and had hypercalciuria. Both patients completely normalized their labs during the time period they were on rifampin. And then in case number 2, this patient came off rifampin, and you can see that the calcium returned to the high level, the PTH began to be suppressed. So this group now has an ongoing NIH-sponsored clinical trial to look at rifampin as a treatment for 24-hydroxylase deficiency. The patient that we're talking about, she opted not to join that trial because she was very concerned about the effect of rifampin on upregulating the catabolism of her OCPs, which she relied on both for management of her endometriosis as well as for contraception. I have another patient who's a toddler who is on this trial and doing great. So takeaways from this case, so in young people, just be aware that rare metabolic diseases are going to be much higher in the differential than they are going to be in adults. The failure to catabolize vitamin D metabolites can cause absorptive hypercalcemia as well as hypercalciuria, and that finally new and more targeted therapies can improve the renal burden of idiopathic hypercalcemia, now known as 24-hydroxylase deficiency. So those are my cases. I am happy to stick around, answer any further questions that people might have about these cases. You can throw those in the chat. You can unmute yourself and just speak up. If there are no further questions, I really do want to thank you both for attending this workshop as well as for being a part of this overall CME lecture, and hope you enjoy the last and final day of the workshop of the conference. All right, so vitamin D resistance type 2, and I will confess that I tend to think about these in which gene is effective. So I don't remember which one is type 2. I can. Oh, this is the absence of the mutation in the vitamin D receptor. That's a tricky one. In pediatrics, we usually, yeah. In pediatrics, we end up putting PICs and just doing calcium infusions. I'm not sure how your patient is being treated, or I mean central lines and doing calcium infusions. Yeah, and then hypophosphatasia, it very much depends on how symptomatic someone is. But obviously now there's the enzyme replacement therapy. Historically fairly easy to get approved in kids because of the effect on rickets and the effects on growth. For adults who are affected, I don't have, in my practice, I'm not seeing the adults, but I sort of know of family members of some of my patients. And it can be really hard. The insurance companies, because it's like, $200,000, $300,000 a year as a therapy, um, uh, it can be really challenging to get that approved, even though it's super effective for kind of the pain, the osteomalacia, and the myopathy that these patients have. And we think the myopathy is probably from the accumulation of pyrophosphate. So why can't we give vitamin D to hypophosphatasia patients? Doesn't want to use it. Okay, interesting. So the challenge in hypophosphatasia is that in the absence of the functional alkaline phosphatase, you end up with an accumulation of pyrophosphate. So not only do you not have local phosphate available to generate the hydroxyapatite crystal, but that pyrophosphate actually actively impairs that mineralization. So you really can't overcome it with vitamin D treatment because it's not an issue of there's insufficient calcium and phosphate around. It's the issue that that mineralization is being actively inhibited. And so vitamin D treatment doesn't end up helping that. So patients can be managed symptomatically, and obviously up until 5, 10 years ago were, but the Strensiq can be really, really effective for patients who are symptomatic. Well, thank you for being here.